Hemostasis is a balanced state of our body. Basically, the process that is responsible for causing bleeding and the process that is responsible for causing clotting. It is maintained at a balanced state so that the flow of the blood remains normal. There is no coagulation, there is no extra thinning of the blood. But whenever there is any imbalance between these two states, there results two kind of the disorders. The first one being the hemostatic disorders and the second one the thrombotic disorders. In our today's lecture, we are going to discuss the hemostatic disorders. We will see first we will discuss about the normal hemostatic mechanisms, and then we will discuss about the hemostatic disorders, how they occur, what is the thing that is responsible for causing this imbalance, and actually what is the clinical feature and pathology that will be seen whenever there is any genetic defect, basically that will lead to these hemostatic disorders. So let's start our today's lecture and let's see that how it goes in our body. If we start with the normal hemostasis mechanism, you guys are well aware about the platelets, and you know that the platelets are synthesized in the bone marrow. There the hematopoietic stem cells are present that are responsible for the production of the platelets. Now there is a normal amount of the platelets in our body that is between 1.5 to 3.5 millions. Whenever there is any defect, maybe the genetic defect that can lead to this the imbalance, some defects in the platelets, either the quantity or the structure or organization of these platelets as well, maybe the proteins that are released by these platelets, all of these things can lead to the hemostatic disorders. So let's see first that how what is the normal mechanism of the platelet activation and formation of the thrombus. Now here we are talking about the normal hemostasis mechanism that is in response whenever any vascular injury has occurred. You know, whenever any vascular injury occur, there is accumulation of the platelets, and that accumulation of platelet actually activates the proteins that form the blood clot and stop the bleeding. Here we are talking about that mechanism. So this is a circulating platelet that actually consists of various protein on its surface, as well as it consists of the granules. Now, what are the parts of the platelets? Let me tell you that it consists of the mitochondria, the various dense granules are present inside the platelet. Now, there are two types of the granules that are present there: the dense granules and the alpha granules. The dense granules that consist of the various protein and glycogen in them, the lipids are also part of them, and alpha granules that consist of various proteins like the p-selectin, like the various factors, the coagulation factors, like the Willebrand factors is part of them. So here you can see that on the surface of this circulating platelet, there are the glycoproteins present. These are the specific glycoproteins that are present on the surface of the platelet. Along with that, there is the alpha granule that consists of the Willebrand factors. Other different types of the factors are part of these alpha granules, and whenever these platelets are activated, basically these granules are released, and all of these proteins are then present in the activated form and perform their role. Plus there is the dense granules. Now these dense granules actually consist of adenosine diphosphate, adenosine triphosphate, and also they consist of the calcium, histamine, and serotonin. All of these are part of these dense granules. Now, whenever there is any vascular injury, these platelets go to the injury site. There, they adhere to the endothelial vessel, and after adherence, the proteins that are present on the surface of these platelet, or once the platelet is activated, it attracts more platelet toward itself and form an aggregate that is then supported by the fibrin, and a fibrin clot is formed, and ultimately a blood clot is formed that stops the bleeding. Now, moving on toward the activation. The first step in the activation is the adherence. Now, platelet will get adhere to the surface of the endothelial vessel. Now, on the surface of the endothelial vessel, there are some proteins, there are some receptors present that will help or that will facilitate the adherence of these platelet to the surface. Once the platelets are attached to the surface, then there are some coagulation factor, and all of these things will facilitate that. And the shape of the platelet, that was the discoid shape. Normal shape of the platelet is discoid shape, but when it get attached to the endothelial surface, its shape is changed from the discoid to stellate shape, and it will change its shape. There will be the formation of the pseudopore, and also there will be the second step of this hemostasis process, that is the aggregation. Now there will be when the pseudopores are formed, the granules are released. All the things that are present inside these granules, they will be released. There will be the release of the fibrinogen. There will be the aggregation, and the platelet will attract more platelet toward itself that will attach to the surface of the platelet and form an aggregate. There will be the secretion of the granules that will also release the p-selectin, that will release the fibrinogen, that will be then activated to the fibrin, and finally a clot will form. So this is just an overview of a mechanism that lead to the formation or that lead to the activation of platelet and formation of a clot. If you want to know in detail about this process, then you can visit the physiology course on the sqadia.com, and there you can find all lectures about the normal hemostasis mechanism. Now, if we discuss more about the coagulation process, the process that is leading to the coagulation. Now, obviously, in our body, there is a balance. If there is a coagulation factors are present there, then they are not in activated state all the time. They are present in inactivated state so that the normal flow of the blood is maintained, normal hemostasis is maintained. Now, the question is how they are activated. Now, it is important to know about this activation cascade, or to revise it as when we will study about the hemostatic disorder, then you guys must know that where the defect is present that is leading to the hemostatic disorder actually. Now, whenever is the vascular damage or inflammation, the tissue factor and other microparticles that are circulating in the blood, they are basically activated and they are aggregated or attracted toward the vascular damage side. Now, it combines with the 7A factor, and along with this 7A factor, it is transferred to the phospholipid, and on the surface of the phospholipid, they are then present, and this is the first complex that is formed. Now, let me tell you that there are two types of the complexes that are present in whole this hemostatic mechanism. The first one is, or you can say the three complexes of the procoagulant complexes and the anticoagulant complexes. There is only one anticoagulant complex, but there are three procoagulant complexes, and this is the first procoagulant complex. Now, as I told you that these anticoagulant factors or the coagulation factors, they are present in an inactivated state. They are activated when they are transferred from one surface to another surface. Like here, you can see that this factor 7A, along with the tissue factor, it is being transferred to the phospholipid surface, and then hence it is activated. Now, this complex, what it will do, it will activate the factor 10 to 10A here, and again it can also activate the factor 9 to 9A. Now, once the factor 9 is activated to the 9A, it will combine with the factor 8A. Now, here the second complex is going to form. The factor 9A will combine with the factor 8A, and together they are transferred to the phospholipid surface to form a second complex, second procoagulant complex, that is the 9A factor 8A complex. Now, this complex, again, it is going to activate the factor 10 to 10A. Now, what will happen that this 10A will combine with the 5A factor, and this 5A factor and 10A factor are then transferred to the phospholipid surface to form the third procoagulant complex. And this third procoagulant complex will actually perform the main step, that is the conversion of prothrombin factor to the thrombin. Here, the factor 2, that is the prothrombin factor, it will be converted to the thrombin factor 2A, and then this 2A, or that is the thrombin factor, is going to activate the protein fibrinogen to the fibrin to form the fibrin clot. Along with it, it is going to it is going to activate the platelet. Now this P is for the platelet, activated platelet that will show their glycoprotein surfaces to which the different other platelets can bind, and there is the cross-linking of the fibrin that will lead to the formation of the fibrin clot. Along with that, there is the activation. It also caused the factor of further activation of the coagulation factor 11 to the 11A, and then 11A is again going to activate the factor 9 to 9A, and then there will be the formation of the coagulant 2, and this whole cascade process will be continued. Now, through this whole mechanism, the clot is formed that will then heal the injured site. Now, one thing that we have not discussed yet is the anticoagulant complex. Where is the one anticoagulant complex that I told you? So here is the the anticoagulant complex. The only anticoagulant complex that is present in our body or on the surface of the endothelial membrane, or you can say endothelial surface, is the thrombin anticoagulant complex. Here, thrombin is present with the thrombomodulin, and it is responsible for the activation of protein C. When the protein C is activated, it will ultimately cause the inhibition, or you can say inactivation of the factor 5A and the factor 8A. And obviously, it will affect the formation of procoagulant complex. Also, antithrombin will inhibit the thrombin and will prevent the activation of fibrinogen to the fibrin. Now, this is not the only anticoagulant mechanism in our body. Along with that, there is, with this thrombin complex, along with this anticoagulant complex, there is the antithrombin, as I told you, that is going to block the thrombin. Along with it, the 9A factor, the 10A factor, 11A factor, all of the factors that are activated by this thrombin, they will be inactivated by this antithrombin action. Likewise, there is the prostacyclin, there is the nitric oxide that will prevent the platelet aggregation. And also there are some other factors, the plasminogen will be converted into the plasmin, and that will then convert, that will then affect the fibrinolysis. So basically, this is all the normal process that is taking place inside our body. Like, as I told you, there is a procoagulant processes, anticoagulant processes that are being carried out, and that are basically maintaining the balance between the coagulation and anticoagulation. Now, what will happen when this balance is disturbed? Either there is increased coagulation, or either there is increased anticoagulation. In both cases, there will be disorders. Obviously, either there will be the hemorrhage, there will be the bleeding conditions, or there will be the coagulation, the blocking state. Whenever there is hemorrhage, there is increased bleeding state. This is basically the hemostatic disorder that is leading to increased bleeding, that is leading to increased, maybe that will appear on your skin as simple patches, or that will be large enough or excessive enough to cause the death of the patient. So hemostatic disorders are basically the bleeding disorders that are due to the overactivation of the anticoagulant factor, you can say, or that are due to some genetic defect in the procoagulant factors. So basically, this whole process that is responsible for activation of the platelet and the formation of the fibrin clot, it is affected, that will lead to the bleeding or hemorrhages. So from now on onwards, we are going to discuss about the different hemostatic disorders. So before going into the different types of the hemostatic disorders, let's see what are some main causes of the bleeding, or what are the different causes that lead to the excess bleeding. So there can be the vascular causes, there can be the extravascular causes, there can be the platelet disorders and other disorders in the coagulation factors as well. All of these things are responsible for an excess bleeding because the hemostatic process is going to be affected. So let's see what are the different vascular disorders that will cause the bleeding. There can be the senile purpura, that is a condition going to affect the blood vessels where the blood vessels become more fragile and more prone to the bleeding and hemorrhages. There can be the purpura simplex, and a condition that is similar to the senile purpura but more frequent in the women. Then there can be the glucocorticoid excess that can also affect the normal hemostatic mechanism. There can be the dysproteinemias. Either the level of the protein is affected, the circulating proteins and all of the different proteins that are involved in the clotting mechanism and the normal process of the blood clotting, the activation of the platelet and other processes. Then there can be the allergic purpura. Allergic purpura is basically a condition that is due to the inflammation of the small blood vessels, and that will then lead to the appearance of the purplish spot on your body, and that will lead to the different symptoms of the gastrointestinal tract, kidney, and the joints as well. We will discuss about this disease in detail in our coming slides as well. And hereditary hemorrhagic telangiectasia, that is basically a disease where telangiectasias are characteristic features, and also there is the arteriovenous malformation that is the characteristic of this disease or this defect. Here there is a genetic defect that is responsible for increased or decreased VEGF, that is a growth factor, and cause the clinical manifestations. Now, all of these vascular disorders we will discuss in our today's lecture, but the platelet abnormalities, we are going to cover them in the second lecture of this series. Now, the platelet abnormalities can be qualitative and they can be quantitative as well. The quantitative one is the thrombocytopenia. Thrombocytopenia is a condition in which there is a decrease in the platelet number. Now, this decrease can be because of any kind of the disorder that is affecting the hematopoietic stem cells from which the platelets are synthesized, or maybe some structural defect that lead to the destruction of the platelets. So there can be the thrombocytopenia, and the second one, that the qualitative disorders. In the qualitative disorders, there can be the Glanzmann thrombasthenia, there can be the Bernard-Sollier syndrome, there can be the storage pool disease, there can be the abnormal arachidonic acid metabolism, uremia, cardiopulmonary bypass, myeloproliferative disorder, and liver diseases. Now, these are the qualitative disorders that are going to affect the platelets. The platelets are the main important thing that is involved in the coagulation process. You know that these platelets, they consist of the dense granules, alpha granules. They go to the site of the injury. There they get attached to the endothelial surface, aggregate more platelets, release fibrin, and this fibrin is then responsible for the formation of a firm clot and stops the bleeding. So whenever there is any defect in this platelet, that will hinder the normal hemostatic process. So obviously there will be the excess bleeding, there will be the hemorrhage because of all of these conditions. Patient is more prone to the hemorrhage and at risk as well. Then there can be the coagulation factor deficiencies. Now, coagulation factors are also very important in causing the disease. As you know, the coagulation cascade that we just had studied, how it is involved in the hemostasis. So whenever there is any deficiency, it is going to affect the normal process and it will cause either the bleeding or the clotting. Whenever there is inherited von Willebrand disease, as you know, it is involved in the platelet activation process, then there will be the excess of the bleeding. Then there can be the hemophilia A or B. In hemophilia, what happens that the patient ability of the blood coagulation is very, very reduced because of some genetic defect. That's why the patient is at risk of the bleeding. There is increased bleeding and the patient is anemic as well. Then there can be the acquired vitamin K deficiency of the or antagonism. Now, vitamin K is also very important in the activation of the different coagulation factor. That's why when a patient who will have the vitamin K deficiency, then he is more prone to bleeding, and this can be a cause of the excess bleeding whenever there is any vascular injury or any other kind of the injury. There can be the hemorrhage in this kind of the patient. Plus, there can be the liver disease. Liver disease is important here because mainly the coagulation factors are synthesized there. So whenever any defect, any liver disease, the level of these coagulation factors, the level of the coagulation in the body, all of these things will be affected by any kind of the liver disease. Then there can be the disseminated intravascular coagulation. That is basically the formation of small clots in whole blood vessels at different spots. At different spots, different small clots are formed that obviously hinder the normal process of the bleeding, and that will lead to the obstruction or hindrance to the normal flow of the blood. So these are all the disorders that can lead to the bleeding, that increase the risk of the bleeding, and that make patient more prone to the bleeding disorder and the hemorrhages. So we are going to cover all of these disorders in this lecture in detail and in our coming lectures as well. Now let's start with the extravascular dysfunction or the extravascular disorders. There are three main extravascular causes of the bleeding. The first one is the senile purpura. Senile purpura is basically the disorder that is common in the adults or the old age person. It appears like this, as you can see, simple reddish spots on the body. Basically, what happens that the pathology behind this disease is that in the old age or the older age, the blood vessels, they become more fragile. That's why these disorders occur commonly in the older age and in this kind of the patient. Then there is the purpura simplex. It is just similar to the senile purpura, but the difference is that it is more common in the females. Females are more prone to the purpura simplex disease. Now, this is also a bleeding disorder, and that it appears like the red patches or red dots on the skin. Then the scurvy. Scurvy is basically due to the deficiency of the vitamin C that lead to this kind of the disorders. Also, it appears like the reddish spot on the skin, and also this is just a skin associated manifestation of this disease. It also involves the bones and the bony defects as well. So this is also a cause of the bleeding in case of the extravascular dysfunction. Moving on toward the vascular dysfunction. In the vascular dysfunction, basically there is the deposition of the immunoglobulin factors in the vessel wall. That makes the vessel wall defective and more prone to the bleeding. The whole process of the hemostasis is affected. Basically, the reason for the deposition of this immunoglobulin factor in the vessel wall is the three type of the diseases or three type of the condition. First of all is the amyloidosis. In the amyloidosis, the amyloid protein is increased in amount and it deposits in the different tissues and in the different cells that is responsible for the increased deposition of the immunoglobulin factor in the vessel wall. Then there can be the paraproteinemia. Again, there is the increased amount of the immunoglobulin antibodies that is responsible for their deposition in the blood vessel wall as well. And sometimes the arteritides it can also lead to the extra deposition of the immunoglobulin factors in the vessel wall. What is the arteritides? It is basically the inflammation of the arteries that lead to the weakness and injury of the arteries and their walls, their structure as well. Coming to the next disorder, that is the hereditary hemorrhagic telangiectasia. It is also known as the Rendu-Osler-Weber syndrome. Basically, as its name indicates, telangiectasia. Telangiectasia are basically the red swellings that appear on the skin. So here, there is the appearance of the red swellings and patches on the skin. That is the characteristics of this disease. Basically, there is an inherited defect that is responsible for this hemorrhagic condition, and these spots that appear on the skin, these are basically due to the minor hemorrhage that is taking place in the blood vessels or at the injury sites. Now, if we talk about the pathogenesis of this disease, basically there is the defects in the genes that is coding the formation of the complex, and that is coding the involving the endoglin. And when the complex, if we talk about the formation of this complex with the SMAD4, there is the two-way through which this complex is formed, either involving the SMAD1, 5-8 or 2-3. These are all the genes and the complexes that are involved in this process. Once this complex is formed, it inhibits the endothelial cell proliferation and smooth muscle migration. This promotes the vasoendothelin growth factor production. Also, it promotes the endothelial cell proliferation and smooth muscle migration and inhibits the vasoendothelin growth factor production. Now, this is the case when there is the involvement of the SMAD2 or 3. Or this is the case when there is the involvement of SMAD1, 5, or 8. Basically, there is a mutation in these genes that is responsible for the decreased amount of this endoglin, ALK1 or BMP9 that lead to the reduced signaling through these signaling molecules, that is the ALK1 and ALK5, that lead to the increase in the VEGF, that is a growth factor to increase the endothelial proliferation. When the endothelial proliferation increases, it is exacerbated by the stress or the hypoxic condition. And the end result is the arteriovenous malformation, telangiectasias, and manifestations of the hereditary hemorrhagic telangiectasia. Basically, when the arteries are defected, when the vessels are defected, so obviously there will be the hindrance in the coagulation process, hemostatic process. They are more prone to the bleeding, they are more prone to the vascular damage, and that's why there will be the hemorrhages and the bleeding that will occur because of this disorder. Moreover, if we talk about its morphology, this is indicating how it appears, and this is the histological slide indicating the telangiectasia, and this is basically an artery that is representing the hereditary hemorrhagic telangiectasia. Now, if we talk about the clinical features that will be manifested by the patient who is suffering from this type of the genetic disorder, in characteristic clinical features, as I told you, there will be the appearance of red patches, swelling, telangiectasias, but moreover, there will be, the first one is the telangiectasia, as I told you. Then there will be the arteriovenous malformation, the defects in the arteries and the veins, their structure. Then there can be the aneurysmal dilatations. There can be the recurrent hemorrhages, there can be anemia. As there is ongoing bleeding, there is hemorrhages that are taking place. So obviously the patient will suffer from the anemia. There can be the bleeding at the site of the lesion. There can be the recurrent epistaxis, the nose bleeding can occur again, more frequently. and then there can be the gastrointestinal hemorrhages involved, and arteriovenous fistula can also result because of this condition, this hereditary conditions. Now, depending upon the site where of which the arteries and the veins are involved, these are the symptoms or the clinical features that will be experienced by the patient. And this is the extravascular type of the dysfunction. Now let's discuss about the allergic purpura. Allergic purpura is also known as the Henoch-Schönlein Purpura. Another name of this disease is the IgA vasculitis. Now, why IgA vasculitis? Because here these small vessels are involved. Basically, what is allergic purpura? It is a disorder of the small blood vessels. The small blood vessels of any part are either inflamed or defective. In most cases, there is the inflammation of the small blood vessels, and that involves the IgA as well in response to that inflammation. Now, if you see this diagram, it will tell you that this is a condition that is affecting the skin. But this is not the only case. Allergic purpura do not only affect the skin, but it also affects the kidneys, the gastrointestinal symptoms, and joints of your bodies. This is only showing the skin manifestation. In the skin, there is the appearance of the purplish spores or the purplish rash appear on your skin. That is the characteristics of this allergic purpura. And basically, in the patient, what happens, there is the symptoms of the kidney, there are the symptoms of the gastrointestinal disturbance and the joint disturbance as well. If we talk about the incidence of this disease in the children, at earlier, this disease was not present in the children, but now the rate of this disease in the children is increasing. And in the children, mostly it is viral infection, and it heals on its own. As the time passes, it is healed. And moreover, if we talk about the allergic purpura, this disease is in most of the cases, this disease is after some kind of the respiratory infection. In adults, mostly it is after some kind of the respiratory infection, upper respiratory tract infection, some kind of the gastrointestinal disorders, maybe the hepatitis or any other disorder. After that, this disease occurs. The exact cause of this disease is not known, but it is known that there is the inflammation of the small vessels that lead to this allergic purpura. If talk about these clinical features that are presented by the patients who are suffering from the allergic purpura, as I told you first, the skin, when it is affected, there is the appearance of the purplish rash. That is the characteristics of this allergic purpura. Then joints are affected. Obviously, there will be the ache or there will be the pain in the joint. The aching joint will be the characteristic of this disease. And if this is involving the small vessels of the gastrointestinal tract, then obviously there will be the gastrointestinal disturbances. There will be the abdominal pain and other characteristic features involving the gastrointestinal tract. Moreover, the kidney damage is associated with the allergic purpura. Now, the kidney damage can be minor or it can be severe as well. Or you can say that allergic purpura can lead to the kidney failure or the kidney damage. Or if we talk about the complications of this disease, there are two complications. The first one is the kidney damage, and the second one is the bony disease or the condition that lead to the degenerations of the bone. So basically, these are the two complications that can occur because of the allergic purpura. Now, you are familiar with this disease, that allergic purpura is due to the small vessels, the inflammation of the small vessels that is going to affect the hemostasis process. That is because of this bleeding and disorder, there will be the appearance of the purplish rash and other various signs and symptoms, because there is a damage of the vessels. That's why there is the effect. This is affecting the normal hemostatic mechanism inside our body. So let's move on and discuss more about the pathology of this allergic purpura. Now, till now we have discussed what this disease is, what is the cause of this disease, and what is basically the clinical feature, the clinical picture of the patient who is suffering from the allergic purpura. Now let's talk about the changes that will occur in the patient who is suffering from this allergic purpura due to the inflammation of the small blood vessels. Now, as there is the hemostatic process is involved here, it is being affected. So, what will happen in the patient? You can see the leukocytes or the neutrophil debris. It will be present there, as there will be the necrosis, there will be the fibrinogen present, more fibrinogen will be present there, or you can see that say that there is the fibrin necrotic crescent like bodies will be present there, and also there will be the capillary loops. And if we talk about the kidney, there will be the necrotic patches that can be seen in the kidney. There will be the excess of the cells like the neutrophils and other cells that can be seen in the patient who is suffering from the allergic purpura. Here, if you look at this diagram, it is basically taken from the kidney, the glomerulus, and it is showing, if you talk about the part A of this diagram, the part A is from the glomerulus of the kidney, and here you can appreciate the necrosis, and you can also appreciate the small crescents that are of the fibrin. There is the fibrin necrosis, accumulation of the fibrin specifically in the Bowman's area. Then this part is telling you about the loops, the capillary loops that are present because of the accumulation of the different cells, because of the accumulation of the fibrin and necrosis. And these are the two other micrographs that are showing the IgA and C3 protein as well. So basically, the whole hemostatic process is affected as there is necrosis taking place. There is the accumulation of the fibrin, but that is not activated. Instead of maintaining the hemostatic process, it is causing the degeneration. There is inflammation. There is accumulation of excess of the leukocytes, excess of the neutrophil debris, because they are aggregated there, but the vessel, there is the inflammation and inflammatory mechanism, inflammatory response is taking place there. The autoimmune response, the immunity, it is also activated. So that's why all of these things, all of these characteristic features will appear on the slides or on the specimen that you will take from the patient. So that's about the allergic purpura that can manifest as the purplish rash, and that will at the bottom that will have the necrosis, the fibrin accumulation, and the leukocytosis and inflammation of the blood vessels. So this was all about this lecture where we discussed about the hemostatic disorders. Now let's summarize what we have talked about in our today's lecture. We started with the normal hemostatic mechanism. The normal hemostatic mechanism that is important to maintain the flow of the blood inside our body, as there is the two things. There is the hemostasis, that is the procoagulation and anticoagulation. There is a balance that is maintained between these two things. When it is disturbed, either there will be the hemostatic disorder or the thrombotic disorders. Here in the first part of this lecture, we have discussed the hemostatic disorder. Later on in the next lecture, we'll discuss about the platelet disorders and other thrombotic disorders. So here we discuss about the normal hemostatic mechanism, how first there is the platelet that is then activated by the release of the dense granules, the release of the alpha granules. There are the three steps, including the adherence, the aggregation, and the secretions that will then adhere more like platelet toward itself. There will be the release of the fibrin that will cause the formation of the clot. Then we discuss the cascade of the coagulation factor. The coagulation factor, just like the platelets present in our blood in inactivated state, likewise the coagulation factor are present in our blood in inactivated state. Whenever there is any vascular injury, there will be the signaling process, and these coagulation factor displaced from one surface to another surface, and they are activated. Once they are activated, they will carry on this process, and formation of one procoagulant complex will activate the second and the third one, and ultimately there will be the activation of the thrombin that will convert the fibrinogen to the fibrin, and there will be the formation of clot. Moving on to anticoagulant factor, we discussed about the thrombin and the thrombomodulin complex that will inhibit these factors whenever there is the need of inhibition. There is antithrombin, there is the prostacyclin, and also there is the nitric oxide present there that is handling with the anticoagulant state. Then we started with the causes of the bleeding. We discussed the vascular, extravascular, and the platelet defects that are responsible for the bleeding. Then we discussed about the different purpuric conditions, like the vascular condition that include the senile purpura, the purpura simplex, and the scurvy, how they are responsible for the bleeding. Then we discussed about the extravascular conditions that lead to the immunoglobulin deposition, immunoglobulin fragment deposition in the endothelial wall because of the amyloidosis, paraproteinemia, and the arteritides. Then we discuss about the telangiectasias. We discuss that these are basically the disorders that lead to the swelling of the skin, and reddish spots appears on the skin, and there is the genetic defects behind them that involve the activation or inhibition of the endothelial surfaces, leading to the increase or decrease in the VEGF, that is a growth factor, and it can then lead to the manifestation of the arteriovenous malformations. Then we discuss about the allergic purpura in detail, that how allergic purpura is caused. It is basically the inflammation of the blood vessels that is because of some primary infection, or maybe due to some genetic defect that basically lead to the defects in our skin, in our bones, in our gastrointestinal tract, and also there is the immune processes involved that will basically hinder all the normal process of the hemostasis, and there can be the hemorrhages, there can be the bleeding, and there can be the complications leading to the kidney damage and the bony disorders. So this was all that we discussed in our today's lecture. That was all about the hemostatic disorders. So if you guys want to know more about the other disorders, like the disorders that are related to the anticoagulation or the coagulant factor, the thrombolytic disorders, and the platelet disorders, then stay tuned to the sqadia.com and watch the coming lectures of this series and about the platelet disorders and about the thrombotic disorders as well. This was all about this lecture. Thanks for watching sqadia.com.